Clinical vignettes, asthma cases with different presentations. Case 1, mild intermittent asthma. A 16-year-old girl presents with occasional wheezing and shortness of breath, primarily at night and sometimes after exposure to dust. She has symptoms less than twice per week and nighttime awakenings less than twice per month. Pulmonary exam is normal between episodes, and spirometry is normal. Question: what is the best initial treatment for this patient? A. Daily inhaled corticosteroids, CS. B. Albuterol as needed. C. Long-acting beta agonists, daily, montelukast, leukotriene receptor antagonist. Answer: B. Albuterol as needed. This patient has mild intermittent asthma, which is treated only with a rescue inhaler, albuterol as needed. She does not require daily controller therapy because her symptoms are infrequent. Case 2, moderate persistent asthma. A 28-year-old male presents with daily wheezing, nighttime awakenings twice a week, and frequent use of his albuterol inhaler. He has had 2 emergency room visits in the past 6 months due to asthma attacks. Spirometry shows an FEV1 of 65% predicted. Question: what is the most appropriate next step in management? A. Inhaled albuterol SABA as needed. B. Low-dose inhaled corticosteroid, ICS. C. Low-dose ICS plus long-acting beta agonist, LOBA. D. Systemic steroids. C. Low-dose ICS plus. Explanation: this patient has moderate persistent asthma, requiring daily maintenance therapy with an ICS, e.g. budesonide, fluticasone, and LA, e.g. salmeterol, formoterol. ICS reduce airway inflammation, while LAMAs provide prolonged bronchodilation. Case 3, severe asthma exacerbation. A 35-year-old woman with a history of severe asthma presents to the emergency department with severe shortness of breath, accessory muscle use, and an inability to complete full sentences. Her respiratory rate is 30 min, and SpO2 is 88% on room air. On auscultation, wheezing is present, but diminished breath sounds are noted. Question: what is the most immediate treatment? A. Nebulized albuterol plus ipratropium plus systemic steroids. B. IV magnesium sulfate. C. BiPAP or intubation. D. Inhaled corticosteroids. Answer: A. Nebulized albuterol plus ipratropium plus systemic steroids. Explanation: this is a severe asthma exacerbation, and immediate treatment includes nebulized albuterol, SABA, plus ipratropium, anticholinergic, provides rapid bronchodilation. Systemic corticosteroids, IV or oral prednisone. Reduce airway inflammation. Oxygen therapy to maintain SpO2 92%. If the patient does not respond, IV magnesium sulfate, B, can be considered, and intubation, C, is reserved for impending respiratory failure. Case 4, aspirin-exacerbated respiratory disease, AERD. A 40-year-old woman with a history of asthma, nasal polyps, and chronic sinusitis develops severe wheezing and respiratory distress after taking ibuprofen for a headache. Question: what is the likely diagnosis? A. Aspirin-exacerbated respiratory disease, ARD. B. Allergic bronchopulmonary aspergillosis, ABPA. C. Chronic obstructive pulmonary disease, COPD. D. Vocal cord dysfunction. Answer: A. Aspirin-exacerbated respiratory disease. Explanation: AERD is a non-allergic reaction characterized by asthma, nasal polyps, and sensitivity to NSAIDs, aspirin, ibuprofen, naproxen. Treatment involves avoiding NSAIDs, using leukotriene receptor antagonists, montelukast, and corticosteroids if needed. Would you like more clinical cases on asthma complications?